understanding and clarity as possible. So we will go ahead and get started. We always like to put out our disclaimer whenever we're doing any of these presentations, and they are for educational and informational purposes, but we always urge that you do your research, but you can always reach out to us for clarity or to help standardize things for your organization as well, because that's what rules and guidelines are for. So overall, our agenda today, we're going to cover the 2025 updates with a really nice high-level overview, and then we're going to take a deeper dive into some of the most notable changes, and of course, the CMS final rules. There's just so much information to want to try to get as much in as possible, but just remember that we are always here for after. If we don't get to get to your questions, you will be able to reach out to me. You can even reach out directly. I will always be here for you. And we should have some time for a Q&A at the end. So now we are going to begin, and this is the point where I do like to close down the camera so that I can just really dive in and just be here 100,000% for you. So let's dive in. I'm very excited, and I'll see you guys in a minute. Okay, so we have a combined 87,260 medical codes across all 3 professional service code sets. We have a total of 1,009 editorial changes for 2025. And we had last year 74,000 diagnoses. For 2025, we have 74,260. These are our overall changes on our code sets and procedures. They just continue to grow. I don't know what just happened there. So we have some of our most notable updates. We have 252 diagnosis additions, right? So the greatest impacts are in our neoplasms, muscles, and our gastroenterology area. Telemedicine, lo and behold, we're going to get into that in some much great and much needed detail here soon. We just want to make sure that we cover what matters the most as well, our kids and our future. Medicare. For our HCPCS updates, of course, we have 13 new caregiver trainings and techniques. We have additional functional status codes for quality measures as well, and much sought after clarity for G2211. So we will definitely dive into that. But I would be remiss if I did not lead in with what is going on in our industry. If we thought it was bad, it's about to get worse. It's about to get more stringent. Payers are introducing more stringent, what they are calling now as payment integrity models. This is an actual reimbursement policy that went into effect on January 13th of this year. And this is going mainstream with a lot of our payers. This is going to cause more bottlenecks in the revenue cycle. There are going to be more prepayment record requests, and these are going to amplify this year. I can't stress enough that if you see an increase in this area, medical records requests, the payers are sending all kinds of correspondence, you can always reach out to us because it's about preparedness, and we really help our clients with the preparedness in this area. Pre and post payment record requests, this is what they're going to be looking for. So everything that you see on this screen, this is what they are going to pick apart. So that's why it's always important to have an annual compliance audit. And you say, well, what's the difference between an audit and a compliance audit? Well, it's all about the discoveries in a compliance audit because we break down every single aspect of that trail. And out of one comes many in a compliance audit. It's for providers, it's for the coders, billers, and payers, and we even audit the auditors. We then summarize reports for all of the parties involved. We have deep technical feedback for coders and billers. We have high-level impacts and resolutions for C-suites. And then we have sharp and concise education for providers. And it just provides a holistic opportunity for the organization, because the overall goal is to mitigate the risk. CMS. So these is, if you want to stay connected to CMS, which really CMS kind of trumps a lot of our coding rules, is federal. So you really have to just kind of know what's going on with Medicare. They do what's called these referrals for information. You can also stay connected with Medicare through Welter Healthcare Partners, because we need to be in those forums, those lobbies. We need providers and care teams giving that feedback from the clinical standpoints. That's how we get a lot of services to maintain, or how we are able to get a lot of the rules that are already built in to be expanded. So just stay tuned, and you can definitely stay tuned to these referrals for information with Welter. But okay, so now we're going to move into the meat and potatoes. First things first, for evaluation and management services, and there were no changes. So there were no changes for MDM or for time, critical care, emergency department. As you can see, these are some of the other areas that there were no changes in evaluation and management. Also, there were no coding changes in anesthesia codes or modifiers. So that was great. Let's see. Okay, so here we have some important updates or pertinent updates in pediatrics. So we have our newborns through 21 years of age. The periodicity schedule is holding strong for this year. We have these immunizations that are still pending FDA approval, but they are in our code set for selection. And if they are being utilized, they will be paid for, I do believe, as long as they are coded and built correctly, making sure we have those administration codes coded correctly. But we do have a new code for a recombinant 90593. This is the chikungunya recombinant vaccine. And this follows, the code is 90589, but that is the already federally approved chikungunya, but that one is for a live attenuated toxoid in there. And then remote therapeutic monitoring, we call it RTM. We're always thinking about the adults. We're always thinking about Medicare patients or, things that are going on, but what about our kiddos? We have babies and kids and adolescents and teens that are coping with significant chronic conditions, and even some of those acute conditions that have to be monitored sharply. And so implementing a care model for remote therapeutic monitoring is extremely important. It's becoming more prevalent in the ped space for chronic conditions, but even for mental health therapy and physical rehabilitation. So we have some services here that you can set up the initial setup and education. And then we have the monitorization for respiratory and musculoskeletal conditions and even cognitive therapy. So I just thought that this was really important to bring about for our children and our future. So here are some of the pertinent updates for Medicare CMS 2025. We do have more in-depth education in all of these areas, but for the sake of time, we're going to cover some of the most pertinent, or the ones that are direct impacts for more of our volume practices and specialties. But you can always reach out. You'll get all of our information at the end. You can go out to our website, but where we do have more education that is specifically just in detail for all of these rules and guidelines. And we do want to express that this is the day and time that you have to begin to have care modeling in your practices. And we'll get into that a lot more in the presentation. So here we also want to touch on global surgery. So these are some of the CMS updates. So remember, we've had 420 editorial changes in the CPT, in surgeries, path and labs, and even the Cat 3. Again, for the sake of time, we're going to focus right now on the CMS rule, because we know that CMS is one of our foremost authorities, and a lot of our commercial payers even follow behind them. So what CMS is finally proposing is that for major surgeries, which are the 90-day globals, they are proposing that that the providers are now required to put the 54 modifier on the surgeries when you are only providing the surgical component. There is an impact to that, and their transparency is that they want to be able to do their cost reduction, because the provider who is performing the surgeries will not be performing the post-operative care. AMA, who is our coding body, the American Medical Association, went back and forth with Medicare about this to say that, hey, we're already going to have reductions in subsequent procedures that are done on that day. CMS heard all of the objections and they're holding very strong. So we just have these surgical packages where providers are just doing components of the surgery. So we have like our modifier 55. So this is a provider or a surgeon who's only doing the post-operative management. We have modifier 56 where the provider is only doing the pre-operative management of the surgery. And then we have our modifier 54 that is the surgeon is saying, I am only doing the surgical care. This patient will be transferred to another provider hereafter. But I wanted to point out, were you aware of G0559? So this is a new add-on code. This add-on code is specific to a patient who is coming for post-op follow-up. You are not the surgeon. You are not in the same practice as the surgeon. So this patient is coming to you for their post-operative care. And whatever specialty that you're in, you can be in the same specialty, just not in the same group, or you can be of a different specialty. So now your documentation does have to support it. If you think about it, this is kind of a visit complexity, right? Because you're taking on a patient where you actually did not do the surgery. So your documentation has to support that you've read the surgical note. You need to understand the relative success of the surgery itself. Any risk factors that can come up, you want to evaluate the anatomy that has been, that's the affected area. If there will be any complications, and especially if this is not in your specialty, you're going to definitely need to do your research. You want to make sure you stay in front of anything that can progressively happen or any complications. So for that follow-up visit, you would be able to, if this is a patient and you are not the surgeon, you were not in that same practice or group that performed the surgery. This is an add-on code, and this is new, and this is showing the complexity, basically, of you taking on that new patient. And so we all know that surgery is just extremely critical to sustaining revenue for certain practices and health systems. Surgery can take, and it will take a hit, and it can take a hit fast. So we always say surgery should always have an outside audit, always. Audit the surgeons, audit the anesthetists if you have that in-house. You audit the coders, we audit the auditors. You want to audit the system. You want to also audit the billing and the denials. Auditing does not just stop at looking at the medical records. You need to have a holistic compliance audit, and that's what we like to provide. So much is left on the table. You would not believe that even with surgical procedures, the way that your procedures are sequenced matters the most, but when they go out the door as well. So then now we have some new code. We have a new code for safety planning. I think that this is a really special one, especially in our mental and behavioral health space. This is a grand preventive measure. It's outstanding. So the health practitioner personally works with the patient's social, like primary and secondary groups, their significant others, family members, caregivers, friends. Everybody can come together to help resolve a crisis if that patient goes into a crisis, preventing the suicidal behaviors, risky, substance use, things like that, to help recognize the warning signs, the impending dangers that can come. And then you're helping the patient to employ some of those internal coping strategies and using social contacts in those social settings as a means of distraction to help, kind of bring your patient. So this is a really, really beautiful service that is provided for us that's new. And I think it's really important to know that it's out there. CMS has also adopted some new services for digital mental health treatment. So for this service, the healthcare provider supplies a digital mental health treatment device. So these are used to enhance their behavioral therapy plan. So the provider also gives like the initial training and onboarding to ensure the patient understands how to use the device. And you can see here G0554, this is for each additional 20 minutes each month. All of these services can be billed together. They can be billed on the same day as psychotherapy. They can be billed on the same day as an E&M with an add-on for psychotherapy. There's so many great things that you can do in building grander care models for your practices. And so I know many of you are saying, well, what's a digital mental health device? So, we always do our research. It basically can be a device that is provided by the provider. It can be like somewhat like a phone or an iPad. It can be software-based technology, is often accessed through an application or an online platform. So these are some of the things that can be piloted and implemented into your practice. We would love to help you more with that. So now, some of the really good stuff. So first things first for G2211, the core descriptor and the core requirements for G2211 has not changed. G2211 is still an add-on to a problem-oriented visit 99202 through 99215. CMS did give an expansion on it for some very specific services. So that's what we're really going to break down today. So we're going to keep it simple. You do not bill G2211 alone with an annual wellness visit. A problem-oriented visit must take place during that annual wellness visit. So this is the only time that Medicare is saying we can put a 25 modifier on the problem-oriented visit and G2211 can stay. So this is during an annual wellness visit, and it is if there are any other preventive Part B services that are being performed that day. So again, that is, you will see your annual wellness visit, you will see your problem-oriented visit with a 25 modifier, you will see your G2211. Then you will see all of your immunizations, and we're going to make sure that you have this presentation. We have a link here that will give you all of the preventive Part B services that you can provide on that day. Just be very careful, stay within those confines. Do not put it at risk to start just doing anything. If you're given a nebulizer treatment, if you're given a therapeutic injection, again, it goes away. Just remember that it has to stay within these confines that Medicare has provided. They've expanded it, but it's very specific. Documentation matters. So it does still matter for G2211. Especially as we watched it evolve over 2024. What we want to say this year is avoid the visit complexity as to attestations and statements. They've become more cloned in nature. CMS and the payers don't like it. Sometimes we get caught up in just having these templated or just pulling them statically into every record when each patient is different and they're not seeing anything different. So what we want to do now, we don't want to continue to have them poking and prodding. For me as an auditor and as a provider educator, my first focus is principles, your documentation principles, and the integrity of them. So what are some of the ways that we can document the patient provider and the longitudinal relationship and everything like that? Well, your HPI or that subjective, that's your first line of defense. You want to document how the patient is coping with the presenting problems. How are they doing physically, mentally, and emotionally? What's their pain levels? And how are they keeping track with the care plan that you just had with them last visit? You might be doing your My Chart messages and in between. So when you do meet with that patient face-to-face or on video, you're asking how they're doing. And when you document that, that definitely demonstrates that relationship. If it's a new patient, then you will be able to demonstrate your discussion with the patient about their conditions, and things like tracking their BP at home, monitoring their glucose. How are they doing with their medication compliances and things like that, diet and exercise. Your assessment and plan is also a really great place to demonstrate that with the goals of care. You've educated, you're counseling your patient, you've answered all of their questions. You talk about their ability or their inability to understand, which is really important. So that definitely shows that even more of that risk and when they're going to return, always talking about how they return. So we can see G2211 in the documentation without there even being an attestation. So I just wanted to give some tips on what your documentation can look like to support G2211. So we have another new code. This is visit complexity for observation and inpatient. This is specific to an infectious disease, and I do believe that it's going to expand, but this is really exciting. This can be added with the admission codes 99221 through 99223, 99231 through 99233. And when you think about it and you think about infectious disease, and it's not just about the risk of the patient, but it's about the possible transmission of diseases right there, even in that hospital setting. And when you think about how they have to keep these things down and having to go and look through all of these medical records, reviewing charts, assessing the complex diagnosis, the microbiology. I mean, it's just in the vulnerable state that the patients are in and some of the photos that they provide. So there is a new visit complexity specific to infectious disease providers in the inpatient setting. Let's hope that we get more, because if you ask me, inpatient work is kind of always complex, right? So hopefully this will expand over this next year. So now we're going to get into telemedicine. We're going to get into AMA, which is our American Medical Association. It's our coding body who develops our CPT coding book, and CMS. And we're going to talk about some contingency planning because things are getting really serious in this space. So here are some of the key changes. I think it's really imperative when we think about care modeling for your practices, and care modeling is tailored. No one practice is the same, or no two practices are the same. So it's imperative that practice managers and providers are all aware of these non-physician services. These services are being left on the table every single day. And especially as we see how payers are getting more stringent, reimbursement is getting less and less, we have to start thinking about what are some of these services that we can utilize. Our teams are running around every day holding our practices together. And so we don't want to keep leaving, their time and their quality on the table as well. We have so many services that can support what they do. And these are care models that can be tailored to your practice. And so here we have the AMA, our coding body. They have deleted all three of the audio only visits. So these should no longer be an option in your EHR. So hopefully nobody is able to bill for this anymore. It will be denied. And so they have been replaced with about 16 new codes, 17 in total, but 16 that we'll get into. So let's just talk about what the ultimate goals of the AMA, which is our coding body, developing our books. They want to replace all telemedicine, live, video, and audio with its own set of codes. Check. That was their goal. They did it. They also wanted to create their own virtual check-in, which is 98016. Check. They did it. CMS does recognize it, and CMS did delete G2012, which was our virtual check-in. So this is the only one that CMS is going to recognize. And CMS has also officially updated the meaning of telemedicine to mean interactive telecommunication. This is live video or audio only as interactive communication. However, they say that the providers must always be able to provide live video visits. So no matter what it's scheduled for, even if it is scheduled for audio only, the provider must be able to always provide live video. So we're going to get into that some more too. So here are the 16 new codes. And we say, well, Medicare says that they are not going to recognize any of these codes. None of these codes can be billed for any Medicare patient or any Medicare Advantage patient. So Medicare's reasoning, they said, we don't have any programmatic reason why we need to consider these 16 new codes. Why? It kind of makes sense because they have 99202 through 99215 already on their telehealth services list. It's been there for quite some time and it's there for 2025. This would be duplicative to have all of these services on here, but why? Well, the main reason is because the MD, it's the same, they are the same exact descriptors as 99202 through 99215. MDM, time, medically appropriate history, everything is the exact same. So Medicare said we don't have any reason to put these on our telehealth list when we already have a code set 99202 through 99215 to support that. So we do have a little twist in with the audio, but we'll get into that soon. So I wanted to provide the RVU crosswalk because this is Medicare as well. They said, well, the RVUs are pretty much the same, especially for the live audio. You can see the crosswalk and the RVUs they reflect each other. The descriptors are the same. I mean, there's just really no distinction. So Medicare said, no, we're not going to accept these codes because we don't need to add them to when we already have the services that already, kind of crosswalk with it. So now we're going to dig into audio. So here's also a really quick RVU crosswalk, and you can see that the RVUs begin to take a dip pretty early on. Well, what is that reason? So the RUC, which is our Relative Unit Committee, they determined that the in-person and live video visits require more physician work. So they say the audio only, when you're just talking on a phone, they're saying that doesn't require as much physician work. So you can see they started to bring down the RVU crosswalk pretty early on. And I've talked about this with some of our clients and physicians, and they've agreed that it's not as much physician work when it's just audio only. So that's Medicare's reasoning. So now let's take a deeper dive into the audio only. We're going to focus on the audio only because there is just a little bit of a discrepancy or a need for clarity in audio only. Whether you are billing or coding based on MDM or time. The MDM is still the same. It's going to be straightforward, low, moderate, or high for new or established patients. The time is the same crosswalk of time as the 99202 through 99215. But the only thing that is different in this is that they're saying there must be more than 10 minutes of medical discussion. And so it's like, okay, what you want to first consider is, here we go with this more than minutes. So what do we say? I know this was a big problem, like for discharge in the inpatient setting. It says you must spend more than 30 minutes. So some organizations standardize what they want. If you can document that I spent more than 30 minutes, or do you give a solid time of 31 minutes or more? So this is kind of how it sounds, right? More than 10 minutes. So do I just document more than 10 minutes spent in discussion? Or do I say 11, 12, 13, as long as I'm 11 minutes and more? I would say with the climate of the payers today, I would say play it safe. You can say I spent 11 minutes, 12 minutes, 13 minutes, 15 minutes or more, or, this is how much time I spent in medical discussion. I just be mindful if you are considering billing based on MDM, but you got to consider if you are saying I spent more than 10 minutes in medical discussion, but you're billing based on time, will that time be a part of your overall time, or will it be carved out above and beyond your time? Because then that can bump up your levels. So just think about that. And then of course, I want to make sure I give you as much research and as much real-time information as out there right now. Documentation matters. Please update your audio-only statements soon. Be sure to account for the more than 10 minutes that you spent in medical discussion and what that medical discussion was. We do not need novels, of course. And then you say, well, wait a minute, what is a medical discussion? Well, I ripped this apart too, everybody. I ripped it apart. So the guidelines do not specifically state that medical discussion is only with the patient. I've looked everywhere. I've looked in our documentation guidelines. I looked to see if I could find it in CMS. I looked in our clinical responsibilities. I've looked everywhere. We do want to be safe, but let's look at some examples of when we're coding and billing based on time for your overall visit. It's about time and task. So preparing the patient, reviewing tests and records, ordering tests, directing clinical staff, performing evaluations, overall documenting an encounter. But then there are some terms for time and task when it comes to medical discussion. And remember, this is for audio only. Discussing the history of the presenting concerns with the patient, counseling and educating the patient or the caregiver, interpreting and communicating results with the patient, discussing the coordination of care and care goals with the patient. But then we also have in there communicating with other healthcare providers and appropriate sources. Appropriate sources could be lawyers, they could be teachers, they could be licensed clinical social workers. So just think about the amount of time you spend in medical discussion and feel confident about it. And remember, your time is that entire calendar day. So it starts at midnight and it ends at 11:59. And then here, so your telemedicine statements, you want to start getting these a little more updated to kind of fit what Medicare, what CMS is saying in their final rule, is that interactive telecommunications means that the provider is always capable of providing the live video. And so you kind of want to make sure that maybe you want to put that in, update your statement. And then make sure if it is audio only, was it scheduled for audio only? Or did the patient experience some technical difficulties that made it transition to audio only? So I think that is really important. I think it's also important for coding, for anything that might be caught in the back end. So in summary, for telemedicine changes and updates, we have the 17 new code says that Medicare absolutely says they will not adopt. You really have to, this is about payer behaviors, and we will have some more telemedicine service webinars that's just specifically focused on, and newsletters for telemedicine can give you some more real world information and how payers are performing with these new codes. So I think that'll be really helpful. Direct supervision, there is no audio only allowed at all for direct supervision. But you can still be on live video. Teaching physicians can be on live video and incident 2. We still want to make sure we're doing place of service 2 and 10. And I think one of the greatest updates that kind of had us on pins and needles is that providers do not need to list their home addresses. You can still list your practice. And this is going to be expanded through this year. I have down here, you can see brace for impact for April 1st. What's going on? What's happening is mind-boggling. We are in a teeth-clenching cliffhanger climate. Towards the end of 2024, the powers that be thwarted our 2-year telemedicine extension. This was going to be 2 years for us to get our providers and our organizations prepared to go back to pre-pandemic restrictions. So our former president, Michael Biden, our former President Biden, he came in on December 21st, and he had it passed into law through the American Relief Act. And he gave us a lifeline of 90 days. It was a great flex, but this means that if Congress does not act before April 1st, that we will actually go back to pre-pandemic guidelines, and it's devastating. So I just want to take some time to really walk this back. Without congressional action, key telehealth flexibilities that were in place for COVID-19. Because remember, I think it was 2023, but the pandemic is over. It's officially over. So the extension of these flexibilities were tied to federal continuation for resolution. With this ongoing political uncertainty, a large number of competing priorities are falling in the zone that is being flooded. I don't want to cling and clinch onto hope in this climate. I would be remiss if I did that for you, for our clients. We have to remain vigilant in every aspect. So we want you to stay really close to us through this. Let's talk about what could happen and how would we get prepared for this. So these are some of the scenarios if Congress is not able to come through for us by March 31st. Medicare beneficiaries may no longer be able to receive reimbursed telehealth services from their homes. The rural facilities restrictions will be reinstated. Critical programs like Hospital at Home will face major disruption. FQHCs and RHCs will lose their ability to serve as distance site providers for most of their telehealth services. Providers may struggle to sustain telehealth-based care if reimbursement disappears. Practices, providers, and health systems cannot afford to wait. We can't afford to wait. We can't afford, a Hail Mary like we did at the end of 2024. They gave us 90 days to accept the fact that these things could change. So if they do come in with a lifeline, which a lot of times they do, like that was just December 21st when former President Biden was able to throw us the lifeline, they just might. But I think it is very important for us to prepare for the just in case. We're going to continue to break this down every Monday over the month of March to keep that communication going out there. And so again, unless Congress steps in, we want to help you assess the patient impact. We want to help you evaluate the financial risk, prepare for the patient, provider, and staff communication, and teach you how to use the telehealth payment eligibility analyzer tool. So this tool will help you with knowing what telehealth services you can provide in the event that we don't get a Hail Mary. And then ultimately what we want to do is help you to identify the alternative care options. And we're doing that through our grand care modeling as well. So grand care modeling, we're committed to doing this, that the Welter Healthcare Partners is committed to doing grand care modeling for individual and tailoring it to individual practices. Number one is to educate and protect the providers. And the reason why we want to do that is so that the providers and their care teams can continue to provide the best care and patient outcomes. And the ultimate goal is to optimize revenue, to sustain revenue, and to endlessly and exhaustively research additional revenue streams. It's so important. And so when we look at CMS wants more. What do I mean? Well, just this year, again, they put out 13 more new telehealth services that are centered around their Medicare patients and their Medicare patients not having to come into the office. So why wouldn't we pull this into a part of a grander care model? The safety planning, that's for mental health, period. Doesn't even matter. That commercial payers will definitely accept the safety planning for those mental and behavioral health issues. But for caregiver training, there's even codes for the caregivers' behaviors and modifications to help them with coping with being a caregiver. How important is that? For our kids with chronic conditions, for our seniors and elderly, and even some of the younger and in the middle, I mean, there are issues in every scope, but we have all of these services. So CMS definitely does want to see more centered patient care, and they're offering us all these services. And we just would not believe how much we're doing it every day. Okay, advanced primary care management. I mean, the fiery hoop life is real. This is a very strategic and very comprehensive care model. You can see here what the RVUs are and the the reimbursement that you would get for them. What I wanted to do, this is an episode of care. This is as much of a condensed version as I can provide for advanced primary care management. It is a care model. It is to be implemented. Your diagnoses for your patient population has to be risk stratified. You have to create a pilot. My thing is has your organization even implemented a pilot for chronic care management or complex chronic care management or principal illness navigation or community health integration, behavioral health integration? If you haven't done any of these care models just yet, you might want to focus on them first, because advanced primary care management kind of falls in line with that. So if you already have a successful chronic care management program, then advanced care management could be something that you could, I don't want to say the words entertain, but it could be something that you might want to talk about. But I've done a lot over the years of working and pulling all of the teams that are necessary together, informaticists, all of the doctors, selecting the practices, building up the playbook for from the front end teams, selecting that patient population to putting it into the works. So care modeling is the way to go for 2025, and I just can't say that enough. But there is a lot that needs to be done in advanced primary care. So if you want to know more about it, please let me know. Please let us know. And even in our pediatric space, we need grander care models in our pediatric space. Keeping track of children and their developmental and psychosocial conditions, care that's above and beyond these preventive check-ins that you have to do. You're doing all of the screenings, whether they're neuropsych, cardiorespiratories. Our babies can have so many issues, but let's also think about keeping up with the mommies, the depression screenings. We have to keep them close for mental and emotional changes and shifts. So building a wraparound care model is at an all-time high, but it's about knowing all of the services, and it's about having the resources to come to that can give you all of these services, and then make sure that you are in compliance and the medical necessity to bill for them. Again, documentation is everything. So, many of these services that can be provided is keeping up with the teens. It's really important in today's time. Our adolescents and teens are just in such, the way the world is going. I know I don't even have to explain that, but depression and suicide risk, alcohol and substance abuse, these are all cries for help with our children. So, that PHQ-2, driving a PHQ-9, those are the first places, those are our first line of defense of knowing what we may need to dig into more, and some of the other tools that need to be utilized in providing more services for our kids. So from the kid space, the children's space, to middle-aged adults, and to our seniors and elderly and all of our folks in between, it's all about the models. So we are nearing the end of the presentation here. So I just want to drive it home again, how important grand care modeling is. So stay connected. We will always be your most innovative partners. Providers and their care teams, they just run on fumes. I have shadowed everywhere. I've shadowed in the inpatient setting, in the emergency department, urgent cares, busy peds and gerontology practices and family medicine, as I'm doing this compliancy for the coding and the billing and the documentation. But I see all of the work that's going in with these teams. And it's like, finally, we have so many more non-physician services. PharmDs, even our pharmacists can provide more services. That's, it's sheer fault. So when we look at primary care, peds, internal medicine, gerontology, palliative care, what do we see? We see sheer volume, patients, orders, analyses, documentation, medical decision-making, 1,000 moving parts. We have coding, we have denials, we have the payers. We have to defragment all of those walls now. We have no room for anything else. The fiery hoops that our providers have to jump through, clinical care teams have to jump through. And I can guarantee you, and I'm going to take a step back so we can see if we can answer some questions if there are any. But I can guarantee everyone on this call has asked this question at some point. We see the volumes, we see reimbursement getting lower and lower and lower. We see, documentation and the guidelines for the coding is getting more and more stringent. And don't get me started on now there's an expectation for providers to select more accurate and more defined diagnosis codes. I mean, we have 74,260. So we've identified some issues there that can probably help get straight to it. But I can guarantee you physicians, advanced practitioners, practice managers, chief medical officers, chief financial officers are all asking, what are we missing? We seem to be doing more and more. We may be getting paid less and less. What's happening with our billing? I feel like we're losing money. Or, what are some of the other services that we can provide? What more can we do? It's all about modeling care. C-suites, I know you want to be able to account for your clinical care teams because they can't bill for a lot of things. There are care models that can be developed to track their time and their intensity, because we can bill for that on the facility side, but in the outpatient setting, in a professional setting, we don't bill facility. We don't get to bill for our resource intensity, but we do get to track it. And we do get to look at the millions, I can say millions, but hundreds of codes that they can bill for. It's a lot, trust me. So I will go ahead and pause there because I just love talking about this stuff. I could talk about it all day. So stay the course with us. I hope any piece of this information is helpful. And to build relationships even after this. You can ask questions. We're always here for you. I would just love to stay in touch. We have all of your emails. We're going to make sure that we keep in touch, especially with this telemedicine and how these things are going, and just staying together. We need each other now, the way things are going. And I think that it is time for organizations to have partners, to see you stand up, to say it look like, well, wow, it looks like they're trying to work themselves out of a job. No, what we're trying to do is help our providers so our providers can help our patients. And so that together we can help these organizations. So here's the CEU for today. We will be at the HealthCon, the annual regional HealthCon in Orlando. So if anyone's going to be out there, I'd love for you to come and find us and say hello. And I think we can leave it open for questions.
We got a first question from Elizabeth. Folks, real quick, if you have a question, please put it into the chat area. It's the third button from the right on the bottom corner. And we'll get to them as best we can. So Elizabeth has a question in the chat.
Oh, okay. Well, yeah, I see one from Teresa Mendoza as well. Will we be provide? Yes, absolutely. I think that's the most important thing. So yes, we will be providing the presentation. So we have everyone's email here. It looks like Elizabeth, any adding or deleting code for surgical procedure codes besides modifier 54, 55, and 56? No, so what we covered today, these were just the CMS final rule, saying that they want to see these codes. I think that a lot of times we really don't think about the providers, let's say in the emergency department, they might do a closed fracture reduction. They will not be providing any more follow-up care. They may not have a practice. And so that patient is going to maybe follow up with an orthopedic, provider outside of that group or outside of that organization. And so they just want to see when that procedure is done that the 54 is put on there, or that 55 and 56, but there were no more call outs by CMS in the modifiers. And then overall in our coding book, there were no modifier changes. So I hope that helps. Okay, so we have, what is the difference between chronic care management and advanced primary care management? So chronic care management, the patients do, there are different levels, and Brady Asprey, I'm not sure what your email address is, but mine is here. So if anybody wants to send me an email, please do, and I can send you, because we have detailed information that breaks down all of these different areas. But chronic care management, basically there's a time component of how much your care team is supposed to spend towards the patient throughout that month. That is also a pilot where you have to do risk stratification for diagnoses. You have to get your population of patients. You're going to want to figure out with your front end administrative and care teams, how are you going to advise the patients to get their consent to move into this monthly program? And of course, the complex chronic care management pilot, or not pilot, but care model is, it's a little bit more involved. The patients are at, a much higher and more severe risk. But it's just a matter of documenting the time, and it's directed by a physician that is directing the care team on this communication with the patient throughout the month, making sure that the patient is receiving like their medications, medication reconciliations. The patients are sending messages back and forth. So this is another way of tracking the intensity of your team's work. So as long as you're able to capture that information, let's say in an episode of care, that's why I say it's a pilot, then you will be able to bill for that code. They are billed once in a calendar month. Advanced primary care management has a whole lot more moving parts. There is no time restraint or constraint with advanced care, primary care management. Pretty much all of the requirements for the patient, one chronic condition or two or more chronic conditions. There's one for Medicare patients only. But the only thing is that they want to be able to see throughout the month that you are doing a whole lot more, what we talk about, that grand care modeling. That's one thing that I really do love about it. So those are just some of the differences. Let's see.
Real quick, Delana.
Yes.
Folks, the webinar is over at 3, but as long as Delana is available for a little bit, we'll keep taking questions as long as her availability is. So people need to drop off because of time commitments and so forth. The actual, webinar is over at this point, but we're more than happy to stay on there as long as Delana is available. So Delana, keep going as long as you need to.
Okay. Thank you, John. So I think we have a question in here. G0560. Is this something a family physician? Yes. Yes. Yes, absolutely. This is safety planning. And there is nothing in the description or the clinical responsibility that says that it has to be a psych provider. I think that because mental and behavioral health is at an all-time high, there's also no age limit. We have to continue to be able to provide, and this is a preventive measure. So yes, you're going to want to be able to provide this service if you know that your patient is having these issues. So I hope that helps. Yes, it does. Oh, thank you. Thank you, Denise. Are the behavioral health advanced access codes specific to behavioral provider types? Let's see. I can go back in the presentation on that one. Oh, yeah. Let's just look at it while we're talking about it. There we go. So you're asking, are these specific to like the G0552, G0554? Are these specific just to mental health or behavioral health providers? So when I go in and I look at our clinical responsibilities, there is nothing that is specifically saying that these have to be mental or behavioral health providers. Just as an internal medicine, family medicine, or pediatrics, gerontology, if you identify that your patient has some anxieties, some depressions, and let's say you've given them a referral, you've worked with a wraparound for them with your licensed clinical social worker, but you want to track and monitor how your patient is performing throughout and keeping a track, and these are some things that can be of a good help with your care teams. But I don't say usually in our clinical responsibility, it will tell us that it has to be like a psychiatrist or something like that. And a lot of practices have like licensed clinical social workers embedded. So, wanting to learn more or, need more information on this as a breakdown of all of the requirements, just reach out to me. Probably each of these slides that we went through, each slide has its own like 2 or 3 pager. So I would love to be able to help you more with that. Let's see, let's get back to there we go. G054. Can you send Dr. Abrams more info? Yes, I can send that for Dr. Abrams. You're welcome, Laverne. G05, Laverne, my lovely Laverne. G0545, is there a list of infectious disease? I don't understand the question, Vijay, I'm sorry. Is there a list of infectious disease released by CMS? I don't think I understand the question. And that's for the add-on code. So I'm not sure, Vijay, if you can give me a little more clarity.
And if it's easier, Vijay, you can unmute yourself and talk to the group since we're in the question and answer section. That helps.
Yeah. So either that, Vijay, you can still, everybody can email me. I like to have that direct and that personalized contact. And then once we make the connection, I can give you more of our internal resources. And we do have like an internal distribution email as well. We do have to see it, a lot of it based on specialty. But that's it, John. It looks like that was it for the questions. Yep. And I know it's a lot of information. Yeah, it's a lot of information. You'll definitely get the slides. And if there's anything else you need, please reach out.
A lot to take in in an hour. Folks, a couple questions came up. Where will we be putting this presentation? We'll be putting it in on our website in a password protected area, so just you can see it along with the video in case you want to go back and review it. We'll be getting that out in the next couple of weeks, so you'll have that. So everybody who signed up and they have their email, we'll send it to them. If again you need any other questions that we haven't answered here, or just think about it later, please email Delana directly at dwilliams@welterhp.com. It's on the bottom, and don't forget about your CE code, your CEU from AAPC. With that said, I think we're gonna wrap. If anybody has any last minute questions, please put them in. Otherwise, we're gonna call it a wrap at 3:03. We appreciate everybody's participation and coming in this year. So
thank you.
That's it.
Thanks,
everyone.
So hard to capture everything. So any questions you have, anything that wasn't in the presentation, reach out.
Thanks, Delana. You did a great job. Thanks everybody for coming in today, and we'll see you in the next webinar. Take care.
Take care.
Bye.
Bye-bye. Bye, everybody.